Honor to be able to introduce here Dr. Susan Skochelak, and my role on the board is I'm a networker, for those of you who know me, and a bit of a librarian, so I'm going to make two key points here. A message to all of you coming from, I think, the passion and heart of Jeannie Johnson of what the profession needs. So let me give you a little bit of background about Dr. Skochelak. She's a nationally recognized authority in medical education. She's pioneered new models for community-based interdisciplinary medical education, innovative programs in rural, urban, global, and public health. She's a member of the Institute of Medicine's Global Forum on Innovation in Health Professions Education, the Liaison Committee for Medical Education Council, the Coalition of Physician Accountability. In 2015, she was elected to the National Academy of Medicine. So now my two key points. Dr. Skochelak was serving as the Senior Associate Dean for Academic Affairs at the University of Wisconsin School of Medicine and Public Health. And she was the director of the AHAC, of the Wisconsin Area Health Education System, where she was principal investigator for over $18 million of grants. And a lot of that is in rural practice. Then she was recruited by the American Medical Association, the AMA, to serve as the chief academic officer and group vice president for medical education at the AMA. They needed a leader like Dr. Skochelak to lead the AMA's accelerating change in medical education initiative. This is how I connected with her, the work that was done by that and the books they produced. It was the initiative to promote innovation to align physician training with the changing needs in our healthcare system. The initiative focused on competency-based education, approaches to medical education, individualized pathways for students, training in health system science, and enhancing the learning environment. Since 2013, the AMA has awarded more than $40 million, it'd be nice to find that, to grant funding. We could find some money, though, if we work together, to medical schools, residency programs, and health systems to transform medical education through bold, rigorously evaluated projects to create the medical schools of the future and reimagine residency training. My second point is she's the lead author of a textbook. She's autographed mine. Second edition, Health System Science, on this topic was written for medical and health profession students, and it's now in its second edition, where she and her colleagues discuss the critical importance of systems thinking that has an emphasis on complexity, depth of insight, and metacognition, all essential elements, and this is an important point, of professional identity formation. Transformational leaders are those that possess expertise, listening to the concerns and needs of team members, value their contribution, and earn the respect of all. And that describes Dr. Skochelak, who is a transformational leader. Please join me in welcoming her to our conference.
Well, good morning. I was so impressed to watch all the energy in the room as you came in and found your seats. I love coming to these kinds of conferences. You get out of your shell, you have the opportunity to see old friends and meet new ones. You get energized, you steal ideas to take back home. You forget what the drudge is like on a day-to-day basis, right? So what an honor to speak with you and hopefully give you some new ideas. And health system science is a bit of a no-brainer because you get out of your training and you get into your environment, whether it's an inpatient practice, clinic, consultation, whatever you're up to, and you look around and you think, oh my gosh, nobody told me this is what it's really like, right? You weren't prepared for what it takes to work in a system. And as an educator, it always bothered me that our students would graduate from medical school and they would not know the difference between Medicare and Medicaid, right? We didn't teach them that they would be smart enough to learn that, but we didn't bother to put that in front of them, even though patients really want some help with some of these things that relate to questions about insurance, et cetera. And then maybe one of the most important things to remember is that we're all, as a health profession, struggling with burnout right now. It's been a rough decade, and you can only do so much meditation and yoga and running. You got to fix the system in order to feel better about your work environment. And when you train your learners that the system is a system that can be affected, can be changed, can be improved, we're on the right path to solving burnout. So thank you for letting me be here. And Gail, thank you for that wonderful introduction. That sounds great. So just to get it out of the way, my conflict of interest disclosures, I'm now emeritus, but I did work at the AMA starting in 2009. My academic colleagues couldn't figure out what the heck I was doing at the AMA, and I wasn't sure either, but oh my gosh, what a dream job. When you end up having $40 million to give out to people, you have a lot of friends. So now, what I will tell you is AMA does not look over my shoulder about anything I say, doesn't check the slides, none of that. So I can feel completely free to say and criticize if I choose to do so. Secondly, as Gail said, I'm the author of a textbook, and all of the authors in this textbook have chosen to give our royalties back to the AMA, to an education fund that goes to conference attendees for students. So if you're wondering about the textbook, yes, it's there. We get royalties, but not personally. So I hope after we finish our hour together that you will understand the concepts of health system science. You'll be able to describe examples of curriculum innovation and implementation. And you will think about the benefits and outcomes that comes from working together. You'll hear a lot about our consortium, and that was an important part of how we achieved the success that we have. And finally, both a little bit this morning and in the follow-up session, thinking about how health system science concepts applies to physical therapy education. It's in your competencies. I know, because Carmen sent them to me the other day on the internet. The question we had was, oh, we're supposed to teach that? How do you do that, right? So that's what we'll talk about. We'll start with what is health system science and how did it develop, and do a deeper dive into the idea of health system science. What is it all about? How has it been integrated into medical education? What did we do working together as a consortium? And what about some future directions to consider? Now, in terms of health system science, let's get the definition out there right away, because not all of you would really know what am I thinking when I say health system science, right? And there are a couple definitions. I chose to take the one from the textbook, and this is the one we've been perpetuating in the literature. Health system science is about the principles, methods, and practice of improving quality and patient experience, outcomes, and costs of healthcare delivery for patients and populations within systems of medical care. Those of you that follow the IHI triple aim in improving care are going to pick right out of there. We're talking about improving quality, improving patient experience, and lowering costs. It goes hand in hand with the goals of Medicare, Medicaid, and IHI and the health systems in terms of what they're hoping for the triple aim outcome. Health system science includes the study of how healthcare is delivered, how healthcare professionals work together, or don't sometimes, and how to improve the healthcare system. Now, in terms of health system science, for medical education, we say it's become the third pillar of education. You used to be able to get away with clinical science and basic science and graduate. And then we started adding a whole lot of topics that often were added individually at different schools, depending on who was the local guru or expert that knew what they wanted to cover. Things like the structure of the healthcare system, or clinical informatics, or epidemiology, or health systems improvement. what we determined was that alone, these are just topic courses, but together they become the foundation of what our learners need to know and understand as they enter into their next 30 and 40 years of practice life. Now, how did health system science develop as this third pillar of medical education? About 15 years ago or so, when I started working at the AMA, it became very clear to those of us in medical education that medical training really was not matching medical practice in major ways. The whole healthcare system was and continues to evolve away from the acute model with one physician, captain of the team, one patient in the clinic or the hospital, to needing to understand and address chronic care, teamwork, populations, community, and our learners were not experiencing or understanding how to deal with any of this new form of practice-based care. At the same time, in 2010, it was a centennial anniversary of this guy from medical education, famous to us, probably not as famous to you, for good reason, Abraham Flexner. Flexner wrote a report in 1910 that changed the face of medical education. It was a report that was commissioned by the Carnegie Foundation for the Advancement of Teaching. But I'll tell you a secret, the AMA was right behind it in interesting ways, getting him up and running. You know, Flexner did some really good things. He went around and visited all medical schools, and he talked about the ones that were good. He thought Hopkins was the best. It was a European model that was associated with the university. And at the time, in 1910, most of medical education was out in the boonies, really, in many ways, as an apprentice model. And he felt that classes, rigor, courses, standards were all important, and really changed the face of medical education at the turn of the last century. You know, in the first 5 years of when his report was published, 65 medical schools closed. However, there were unfortunate fallout from the Flexner report as well. All the women's medical colleges and all but one of the Black medical colleges closed. The rural schools and the focus on rural and community virtually disappeared from medical education. So with the good came the bad, and 100 years of legacy of standards that were very influenced by Flexner. Well, it's a centennial. What are you going to do but do a review and write a report? And there were a lot of reports. And what was interesting to see in that decade from 2010 and into the time when we started this work in health system science is that really there was a growing consensus that emerged that medical education needed reform. Now, this won't surprise any of you. When have we ever said that health profession education doesn't need reform, right? Every year you come in, it's a new idea. That's good, I guess. But here was an opportunity, a sentinel event that allowed for quite a bit of consensus across the community. There were reports like the one at the top that came from the American Hospital Association talking about what they needed for physician leaders in healthcare. The one in Health Affairs talked about surveying new entrants into practice and the gaps that they came in with in terms of medical knowledge and practice from residency into the transition of practice. One that I wrote was a summary of 10 years, 15 reports from major organizations of what needed to change in medical education. And no surprise, they all virtually said the same things. There was good consensus about what needed to change. At the same time, our national organizations in medical education were embarking in new directions that have been very exciting, and I know it's been part of your professional education pathways as well. You know, the first one out of the box really was the ACGME, the Accreditation Council for Graduate Medical Education. that sets the standards for our residency training. And they developed 6 competency domains and said all graduates need to be proficient in these 6 domains. In fact, 2 of those domains, systems-based practice and practice-based thinking, of course, fit right in with health system science. And they were the 2 that we all said, how the heck, what do you even mean by that? Would you please define it? We weren't really familiar with the language. Now, of course, the ACGME has moved on way past that to develop a whole milestone framework by which they measure their graduates in all residency training programs on a regular basis in order to guarantee their competence for graduation. And if I remember correctly, I think you had one of my colleagues that has worked deeply last year for your talk in the area of entrustable professional activities. The AAMC started out with these core activities to say, we want to guarantee when students leave medical school, they all will be able to do a set unit of work so that when they enter residency training, we'll feel comfortable that they know what they need to know to start their next level of training. So national standards getting going. Well, AMA in the meantime wanted to play in the space of education. And that ruffled a few feathers with the old organizations that are used to owning, and I do mean owning the space. AMA has legitimacy in this area though, and I'll tell you what. First of all, as I hinted, they actually were a sponsor behind the Flexner Report. The AMA's Council on Medical Education in 1905 to 1910 published a number of landmark studies criticizing physician education until it got too hot. And then they passed it off to Carnegie and said, could we do a study? Would you guys sponsor it? We also are the parents of the ACGME and the ACCME, Continuing Medical Education. These were committees that used to be part of the AMA until they finally grew up and stood on their own and became independent, regulating and accrediting bodies. And finally, the AMA still co-sponsors with the AAMC, the Association of American Medical Colleges, the committee that accredits all U.S. and Canadian medical schools, the LCME, the Liaison Committee for Education, Medical Education. So we did have a legitimate opportunity to say we belong in the sphere of medical education. The other thing that happened about a year after I joined the AMA is we got an opportunity for new activities because of new leadership. They hired a new CEO, Dr. James Moderator. Jim had been the dean at University of Chicago, a pathologist and researcher by training. Interesting guy to come in and lead this big old national organization. Good thing for me was I'd worked for years in the dean's office, and I kind of know how deans like to think. So he was a good leader, and good for me because I had the opportunity to really be strategic. So he took a look at the AMA's mission, same as it's been for years, same still, to promote the art and science of medicine and the betterment of public health, and said, what does this mean and how do we actually live our mission? And he developed a strategic focus initiative. He said, we're going to use 3 areas, we're going to invest our money in those areas, and we're going to try and make a difference that's outcome oriented. And he chose, with the Board of Trustees and through a very interesting process that was broad-based, improving public health, medical education, and practice sustainability and professional satisfaction as the areas for the strategic focus. Well, we were right there on top with medical education. Believe me, I'll tell you the story sometime about how we even got on the list. But we're ready to go because we had the opportunity to say, it's time, after 100 years, to make deep changes in medical education. We developed the AMA Accelerating Change in Medical Education Initiative. And I'd like to tell you just a little bit about that to understand where health system science comes from, because it was this organization that did all the deep work in health system science. So we developed this program based on the literature. I mentioned that we really took a deep look at what the national recommendations were, and we identified the gaps in readiness for practice and said this is where we're going to focus. The management of chronic conditions, management of care coordination, systems-based practice, practice-based improvement, and communication. We didn't have the word health system science then. We just knew that these were the areas that people really identified as gaps and needs. And then we had the solid consensus that had come from 10 years of reports of every major medical organization out there, and a few non-medical ones too, that wanted to weigh in on what medical education should be for the 21st century. We chose 4 goals for the Accelerating Change in Medical Education initiative. We wanted to create competency-based assessment and flexible individualized learning plans. Oh my gosh, do you know what that really means? Students can go on their own pace and graduate when they're ready. Can you imagine 160 medical students in your class and 2 of them want to graduate after 2 years because they came to medical school after being a nurse practitioner and don't need all that extra stuff that they already know? But we really wanted to support experiments and try and change and say, could you really do competency-based progression, not time-based progression? Secondly, we wanted to develop exemplary methods to achieve patient safety, performance improvement, and patient-centered team-based care. All right, it's the AMA saying team-based care. Sometimes you got to take it with a grain of salt. But in med ed, we meant it. We meant it. Understanding the healthcare system and healthcare financing, and optimizing the learning environment through new pedagogy, new tools, and new technology. So that's what we said we wanted to achieve, and our board was going to hold us to it. If they're going to give us money to give and spend on these initiatives, we had to define what we meant by these things, what outcomes we would be looking for, and report back to them regularly at their meetings on our progress for achieving these goals. Well, I am steeped deeply in academics, and I think like an academic. And I thought, I know the thing that will get to these schools more than anything else, money and prestige, right? So we established a grant program, a big competition. And in fact, I argued with Jim quite a bit. I said, you know, let's do something that really will move these schools. There's tons of money out there in the research environment, but there's not very much money in education. It's so scarce. If we do something big, they will go for it. I believed it, and he was skeptical. He said, fine, we'll pick 3 schools. And I thought, this is so AMA. We're going to pick 3 schools and say, we're changing the world with 3 schools. You know? So I presented to the board back and forth, got him to agree with, well, 8 to 10. You can have money for 8 to 10 schools. We'll see what the quality of the projects are that you get. Well, believe me, when we let out the RFP for the grant, we had 85% of all medical schools in the country going for this. And we had amazing proposals. We had an external team of academics and other renowned people to choose. And they thought the proposals were so good that they actually went back and asked the board for an extra one, which is how we ended up with 11. So we had 11 schools to start with in 2013. We expanded by another 21 schools with smaller grants in 2016. And the important thing that we did was we formed a consortium with these schools purposefully to jumpstart and speed the dissemination of ideas. And the consortium became a venue for collaboration, innovation, and scholarship. This is our family of schools from the beginning. We have many more now. We're pretty porous. We let people in and out of the group as they wish over the years, 15 years now that we've all been working together. It's important really to note that we did not go for all the marquee schools. Harvard's up there, but it was in the second group with lower money. There's quite a few big name groups that aren't up there. We've got East Carolina Medical School in Eastern North Carolina, UC Davis, Michigan State, wonderful educational institutions and wonderful schools, but not the ones that are up there in the US News and World Report that usually get the publicity. Nevertheless, they came in with some of the most amazing ideas and just humbled us with the work that they were willing to do on this initiative. Now, if you remember the goals that I mentioned, we already had health system science baked into those two goals. Goal number 2 and 3 together were the source of many projects for these schools, and they formed the basis for health system science. Now, early on, we faced two major obstacles at every institution and within the ACE program itself. Faculty development, right? We don't know this content. We didn't learn it. We don't know how to teach it. We're not comfortable with it. And some of the folks in this room are now, right? But many of us are not. It depends on your time and training and where you've been employed and the additional education that you might have received. But certainly at 2013 with medical faculty, people just didn't know this material. And we really had to start from scratch in terms of teaching materials. We didn't have not just the content for lectures, we didn't have things to assess, we didn't really understand the best ways to deliver this curriculum. And believe me, it's not lecture-based. So, the consortium is what we put together purposefully at the AMA to say, we're not just giving you $1 million for 5 years, we're forming a community of practice, a community of learners. And this is my message to you to think about here, since you're at a conference with wonderful associations supporting all the work that you're doing. Why is it important that you come together regularly and form a consortium? We structured it so that we would meet twice a year with the grant teams. So it'd be about 150 people by the time they brought all their teams and got together, shared, paired, did presentations. We met monthly with the PIs, and we formed interest groups around the kinds of themes of what they were working on. New technology, health system science, and it was the AMA staff teams that facilitated making sure these conference calls happened, et cetera. We made sure to go out to the schools and do site visits, and we did this on purpose, in part to help the PIs. Because if you think those curriculum committees out there in those schools wanted to let these changes happen, you haven't lived with a curriculum committee, right? Why do we have to do this? There's no time in the curriculum. We're not going to do this. Well, if the AMA's grant team showed up at your site and met with the curriculum committee chair, it gave the PIs a lot more leverage. We planned student-focused meetings. We really wanted to learn from our learners, and they were wonderful. They told us what was working and what wasn't working, what they wanted out of their education, and they planned their own meetings. We sponsored them and had them annually with students from all the programs. Now we do an annual conference every fall. We just had it a couple weeks ago. And if you'd like to hear more about the specifics about any of this, AMA's website is www.changemeded.org. Lots of information there for those that want more. What I'd like to do is give you a flavor of the consortium from the first year of when we worked together. You can see what they say about their work and themselves to understand why I think this was the most important thing that AMA did in this whole initiative. We're turning the ideas into action through a consortium of schools that are innovating new projects to make medical education easy. This is truly a good job for medics
to take the best of all programs. Well, a collection of components in cases there's velocities, group exercise, vegetable training.
Project about a new kind of clinician that understanding population health is able to think about a new system of care.
It's kind of jumpstart the process of improvement that we want to see in healthcare systems, boosting our very, very talented and purpose-driven students, and helping them understand that being a physician in the 21st century, it looks a lot different than being a physician in the 20th century.
There's no sense that it's possible about what they're experiencing now, even like those community people. You don't know the skills to create a business people. That's where they'll be able to
Have to be ready for this 4 years to provide the offices and physicians to the
We're going to do it faster and we're going to change
shoulders and work together to move this forward. I think it's fascinating because each of us are and yet they found us common ground here at the debate and pay and across these different focus areas to work together.
What a privilege to work with these people, the energy and enthusiasm and vision that they had. So, one of the first things that we did was publications. We had to find the common language. And since we were all going down the path at the same time, we formed collaborative groups to put together our first textbook, published in 2016. A little bit premature, we revised it fairly quickly, came out with the second edition in 2020 because we learned so much and we refined the content and the language quickly. And then followed up with a number of other supporting textbooks and materials to help schools at all levels. Now let me jump back for a minute to what is health system science, because if you want to understand what can you do with it in physical therapy education, you want to understand what is it that you're talking about, what is the universe here. So I started with this definition that echoes in some ways the IHI's triple aim about working to improve outcomes, reduce costs, understand the healthcare system. And we have developed 12 domains for health system science. And this wheel of influence is in the textbook and all the materials that we put out. Let me tell you a little bit about these domains, and it'll start to come together for you in one big picture. We first start in the center with the core functional domains and put patient, family, and community at the center. What are the patient's goals? What is their clinical context within their family and their community? And then understanding the healthcare structure and process, healthcare policy and economics, clinical informatics and health technology, population, public, and social determinants of health, value in healthcare, and health system improvement. Then there are 4 overarching foundational domains that cross-cut these original 7. Change agency and management and advocacy, ethics and legal issues, leadership, and teaming. And finally, surrounding the whole concept is the idea of systems thinking. How to be a systems thinker, a good systems citizen, so that you can make the change that needs to happen to improve outcomes. So it's those 12 areas that the book is based on, that our assessments are based on, that the modules are based on, the curriculum is based on. They all come together, and not every school teaches every domain. They pick and choose a little bit, but I can tell you it's a lot easier to go to your curriculum committee and say, I need a block of time for health systems science than to go and try and introduce 6 different topics off of this list of core functional domains. And still, I know you can't read this in the back, so I'll just tell you what the illusion is. The purple in the top is about the care of individual patients, and that's currently what most of us teach to. Basic and clinical science, working in the clinics and hospitals. It's the iceberg underneath that health system science is all about. And it has topics up here that include policy and healthcare reform, systems improvement, teamwork, and interprofessional collaboration. And what we need in health systems education is early and continuous immersion in the workings of the healthcare system to actually gain competency in how to function effectively. Let me make it real by giving you some examples that may translate very well to the kinds of environments within which you're teaching. I'm going to start with systems immersed in having students participate to bring value to them. This was a concept that came from Penn State College of Medicine. Penn State had already been quite strong in patient navigation. They had programs in patient navigation, in cancer, in aging, in diabetes. You probably all do in your environments now as well. They combined the patient navigators with teams of students so that during their first 2 years, students became patient navigators. And the navigators were faculty for the students. And they would go out and make visits with the patient navigators, understand the real world concerns that might be going on with those patients, and work to solve those problems. And they paired those with coursework in health system science that was integrated throughout year 1 and year 2. At first, there was a kind of a skepticism about, are students really going to want to do this? This isn't doctoring, this is something different. But the minute they got there and listened to a patient and heard their story and their dilemma, they were hooked. And they understood where the system was failing. One of my favorite ones from the example when the students were talking about it was the healthcare system there was doing their MRI scheduling 24/7. So they had a woman who was supposed to show up for her MRI at 2 a.m. with a couple of little kids at home. You know, I don't know that they solved that problem. I get why they schedule the way they do, but it just reminded us from a student standpoint, they get to see the system from the patient's viewpoint and understand that our system can fail in surprising ways many times. Now, East Carolina University had a different approach. They said, there's no way we can teach this. This is too big of a job and nobody on our faculty knows how to do it. So we're going to form a faculty teaching academy for 2 years before we do anything in the curriculum. And they went to their healthcare system. Yeah, right? Don't just throw you to the wolves. They went to their healthcare system and they said, you want us to do this. You want us to be better system thinkers and you want us to improve care. If you will give our faculty in the clinical departments 10% time, 1 day a month, we will come together and we will take the IHI Open School on practice-based improvement. We will do quality improvement projects. And they worked in teams as faculty, figured out how to understand this material and how to teach the material, and did QI projects. Now, what healthcare system wouldn't love 50 quality improvement projects on improving wait time in their peds ER? You name it, they came up with it, and the faculty were able to learn before they leashed themselves on students. They also developed a special track. So that's another option that people sometimes choose, doing tracks rather than deep for every student. Some students will want to do this more deeply, and they developed a Leadership Academy track for a section of medical students. And then finally, I just wanted to mention a little bit about NYU's Grossman School of Medicine. You heard a little snippet of Mark Triola talking on the video, that they developed something called Healthcare by the Numbers curriculum. They took their data from their healthcare and de-identified it and dumped it into an EHR and then put it in front of students and asked them to understand what that data could show you about clinical problems and clinical outcomes. So they had all the students start, based on patients they were seeing, start to ask clinical questions. And then based on those clinical questions, the faculty would help them go into that database and look at the health system's outcomes in that area. In addition, they developed an e-portfolio for students so that they could actually track their own patient care experiences. So they really wanted to use technology in a new way and to make sure that they understood the benefits of working with that technology to improve your own care and improve the health system. Now, the biggest problem everybody had in the beginning was this felt like broccoli. The students did not love this stuff anywhere near as much as we did. I promise you that. It's tough, especially if you're used to the old pedagogy of stand up and give them a lecture on any one of these topics. So what we learned during our time together and kept reinforcing is that you have to have authentic learning experiences as a part of this curriculum. Whether it's a patient navigator or looking at your own patient data or solving a clinical problem, it's got to be real world. Don't do paper cases. The more you can connect it to real patient care and outcomes, the more the students find it valuable and useful. It really needs to be integrated within existing curriculum. So a one-off course on informatics and a one-off course on communication skills is easy to lose in the milieu of everything else that they're doing. But an integrated course, especially as you can connect it with the other learning experiences, is the way to go. I already mentioned the importance of faculty development. And you have to do meaningful assessment. Our students are smart. They're not going to spend time on something that they don't get evaluated on, they don't get tested on, and they don't have to demonstrate knowledge and proficiency in, right? It's just a drive-by course then, and you're lucky if they'll participate. So more on that in a minute. Let me say a bit about long-term outcomes and what we found after working together for a decade with these great schools. First, there's just the outcome of the grant itself. After finally putting in about $14 million directly to these schools, we ended up reaching 23,000 medical students with our curricula who provide care for more than 40 million patients annually. So that's in and of itself an outcome that we were proud to participate in. We partnered wherever we could with the other associations, AAMC, ACGME. Elsevier happened to be our publishing partner, but you might have your own university presses. But the organization that I found the most valuable for assessment purposes was our national boards, National Board of Medical Examiners. Because if it's not on the boards, it's not in their minds, right? So we spent about 2 years working with the NBME to get health system science content on the board, specifically listed in their competencies of what, when the students go and they have to go and read, what am I going to be tested on? It's in there. And we developed a subject exam. So for people that are teaching this at their school and want to have an exam, just like you have a derm subject exam and you have a peds subject exam, with the wonderful assessment expertise at the NBME, we developed a subject exam. And it was quite a project. I mean, we had to become good item writers, and we had to have them all vetted at the level of quality NBME keeps, et cetera. But to me, that was a very important part of what we ultimately did to legitimize this as the third pillar of medical education. Now, a couple things just naturally came from collaborating. In the first 5 years, we put out more than 150 publications that were cited over 1,000 times, and more than 270 presentations, regionally, nationally, and internationally. And it gets really easy, because if you want to do a national presentation, you know the best way to do that is to get 2 or 3 schools or programs together. They want to hear, compare, and contrast what you learn. They don't want your show and tell individual program. We did consultations at more than 250 organizations. The consortium itself continues to this day, gets together regularly. They're wonderful friends and colleagues. But we convinced AMA to open up their pocketbooks again. Bless their heart, you know, they have these reserves and they're just sitting in the bank. And we said, well, now we've trained all these students and they are ready to go, and they get into residency and it gets beat out of them because nobody expects them to be able to work in a healthcare system. We've got to do better. And so we started another initiative at the residency level, reimagining residency, $15 million of grants to residencies in healthcare systems. This one got hit with COVID. As soon as it was announced and the funds were awarded, COVID started, so they're on a little bit longer track, but all working hard and wrapping up their projects sometime in the next year. And then AMA and especially the faculty at these schools developed learning series modules that are on our website, and we developed a scholars program once a year, inviting faculty from across medical schools around the country to come and learn about health system science in a 3-day workshop so that they could go home and transfer it to their own location. Now, we also have hit the international scene. We've been in contact with people from Korea, from South Africa, Finland, UK, probably more now. I'm retired, so I don't stay on top of this quite as much, but it's been getting good press in lots of different places and a major interest around the world. We have been integrating very closely with health systems. The people that tend to be the biggest friends about this curriculum are not your standard educators, but your CEO, your CTO, other folks in your health system that immediately see the need for this and are willing to actually be faculty, to partner, to help you with projects. There are now within health systems at multiple places deans for health system science. And some of the newer medical schools have fully integrated from the get-go health system science within their curriculum. Always easier when you have a blank slate to start with. But I listed 2 of them here that have got integrated 4-year health system science curriculum. And most exciting to me and grateful to you all is the opportunity for adoption across health professions education. This past year, the National Academy of Medicine put a series of workshops together for health professions on health system science to bring all of us together across the continuum of health profession delivery to say we have more in common than we have apart. How can we share this? And how can our learners learn together? And if you're going to do interprofessional education, aren't these topics the ones, not basic and clinical science? So I thought to myself, what does this mean for physical therapy education? What would I want to tell you if you're going to embark on this initiative? And excitingly, some of you have, of course, and some of you will be talking at the next session about how you've been doing it. I would say an integrated curriculum is key to being, making it visible to students what you're talking about, Why are you introducing these various topics? How do they relate to each other? How do they make you a better citizen in terms of understanding how to survive, change, and improve the healthcare system? Faculty development is critical. I'll take another shout out for that because we know that's true. It has to be grounded in authentic learning experiences. If you are just talking about healthcare systems and they're not in the healthcare system and they're not seeing patients and they're not seeing what's going on, it's just a dry, sterile exercise. But if they can see a problem and you give them the tools to solve a problem and they can see the result, that's grounded in their gray matter forever. You know, we are all focused on capstones and projects, and the material in health system science really lends itself well to this. I didn't talk about UCSF, but let me just shout out for them for a minute. They did a wonderful integrated curriculum, but they did a research day sponsored by their health system for students to take on quality improvement projects. So instead of the usual basic science research, they did a health system science focus, and every year they'll have the best 30 projects that they'll present on their research day about improving the healthcare system. As I said earlier, assessment matters. It matters to your learners. It matters to you as an educator to, are you hitting the mark? Are they learning what you're hoping that they're learning? And this idea of a consortium was the thing that moved us from wishing to doing. And you can do that as well, whether it's at this meeting or follow up with your associations that are well represented here. A consortium of people working together creates and sustains energy and resources. You take it beyond this wonderful energy that you came in with today, feeling so glad to see each other and excited to see what the program is. And you keep that going by moving and focusing on a specific topic within a consortium. I know you could figure out how to do that if you wanted to. Let me express my gratitude today. I wanted to thank the leadership of the ELC 2024 for the opportunity to talk with you about something that I feel very passionate about. It makes me feel like I'm channeling Geneva R. Johnson about passion and persistence. That's what gets me up and going in the morning every day, and I hope it is what motivates you too, working with our wonderful learners and helping to advance the profession. I have to be grateful to my medical education team. They really were the backbone of the work that we did together for 10 years and all the ACE Consortium schools. So with that, I'll close. I'm going to leave you in the slide deck a set of references if interested. I also brought the textbook here. If you'd like to see the textbook, I'll have it out at the reception of the registration desk. So if you want to take a look at it just to see what the topics are, what does it look like? It's made for students, for health profession students, although the language is heavy on medical. It's got a lot of exercises. It's paperback and under $50. All right. Thank you so much.